Good morning, everybody. And I think we have, in theory, a very doable agenda, but we'll have to see how it works out. Can we just start with the minutes of our last board meeting? And I should incidentally congratulate the minute taker. I thought these were excellent minutes, and for example, they captured the Wrightington, Wigan and Lee presentation really extremely well. But do colleagues have any comments, or can we take those as read? Thank you. I think there's really only one action point which David is going to cover, which is our actual inspections versus our inspection trajectory, but that's going to be covered by David. So with no more ado, we can go directly to David's report, please.
Good morning, all. Michael, thank you. At the last board meeting, we had a conversation about performance, and I gave a commitment that we'd bring back to this meeting a further update on our performance. So in the normal and usual Chief Exec's report, we begin with an explanation of where we are up to in terms of performance against the plan and the timetable to complete inspections. Attached to the report is a performance report. And for this month, I hope you'll note that this is accurate until the end of September. So normally this is a couple of months out by the time it appears in front of the board, but this is up to date. So Mark Edmonds and the team of one of Paul's colleagues have pulled this together to give us the up-to-date information as of the end of September. So the current position is that there are three. Let me do the headline. So our ambition to deliver a completed inspection programme by the end of September next year is at risk. We're 11 months away from that, just to emphasise that. So we're doing this in September 2015. That's 11 months before that target date, 12 months before that target date, depending on how you want to count that. And it is at risk of doing that. Colleagues throughout the organisation are working hard to address that. Improvements are being made in terms of systems and processes. You'll see elsewhere in the performance report the time from completion of an inspection to publication of the inspection report is dropping and has dropped consistently across the piece. Later in the Chief Exec's report, there's a paragraph on updating on recruitment, and you'll see that we've made 563 inspection offers to inspectors. So our recruitment process is pulling people into the organisation. And again, you'll see from the report that some 400 or so of those staff have gone through the induction training and are now coming out the other end and being productive. I just need to draw this distinction between people that have been appointed and when they become productive, and as that works through. So that is beginning to make some impact. We continue to monitor this at ET, and each of the chief inspectors are monitoring this performance through their own management meetings and taking action to improve performance. We've now got performance data which is very granular and goes down into some quite fine detail, not just by directorates but by team, and that allows this to be taken through. But the overall picture is set out in the report at the top of page 2, where for hospitals there are 3 key dates here. Firstly, there's a completion of the acute hospital inspection programme, and that is on target for delivery. The second key date is June 2016, which is for other trust. That's community, ambulance, etc. And we're confident in relation to those dates. We're still working through to finalise the issues around the independent sector, hospitals, and we need to do further work on that. The key issue here is in relation to the proportion of re-inspections that are required of acute and community and ambulance trusts that will actually need to be factored into the plan for next year. You'll see from the recruitment paragraphs later in this report that Mike and his colleagues are further away from the total number of inspectors that are required as well, so that has a bearing in relation to this. So there is some risk within the hospital programme, and the quantum of that risk we need to calculate as we go through the next few weeks. In relation to adult social care, Andrea and colleagues are working hard, and improvements around inspection to report production time are examples of improvements that are taking place. But this report is flagging, after a considerable amount of work, that there is risk to the completion of that programme by the end of September. And I think it's important we're clear and transparent about that. In relation to primary medical services, again, improvements are taking place, but there is risk to the delivery of that programme by the end of September next year. We'll continue to work on these issues. There are key challenges around productivity that we need to address, improvements in systems and performance. But I think it's only right, Michael, that we're absolutely clear at this point that there is risk to the delivery of the programme by the end of the year. As I say, we're not saying we will miss it, but there is a significant risk of it, and improvements are being made, and there still remains a risk. So we'll continue to work at this, but I think it's important, given the conversation, the need to be transparent about this and just declare this in an open way. So is it worth me pausing at that particular point and responding to any questions colleagues might have, and then I'll go through the rest of the report?
Yes, I think so, David, although because we're going to be returning to productivity and inspection performance later today, it may be that colleagues, instead of discussing this twice, we could discuss this later. But if there are any particular issues now for David.
Thank you. It's just to get a handle on what the issues in each of the domains, vacancies, processes and productivity, extent of re-inspection activity, or something else. It's just a kind of idea, what is the breakdown, if you like, of those proportions of things?
Yeah, so thanks, Jennifer. No, I think you've got the issues, which are the variables that have been addressed and that we've been addressing as a management team. They are exactly the issues. So they actually impact slightly differently across the different sectors, but it's a combination of those influences working together. In terms of recruitment, that works differently because of progress in relation to bringing people in and recruiting them and getting them good to go has been different. As I say, I think the biggest issue is in Mike's area in terms of recruitment. Turnover recruitment has been good, but in some teams turnover has been higher than was originally planned. So that's one of the factors that's bearing through. I think this is some people just naturally taking retirement. I think some people thinking the new methodologies are not for them, and they're making decisions to leave. I think there have been performance conversations with other members of staff. So I think there's a rich mixture of reasons why turnover is higher. Sickness is still good, but has increased recently. So those issues around staffing begin to bear. On systems and processes, both Andrea and Steve have taken out some of the checks that were in place, managerial checks that were in place in terms of clearing reports, and that has then resulted in improved processes for getting reports out more quickly. Steve's changed the template that's used by inspectors so reports can be produced more easily and more quickly without the quality of those being affected. So all of those feature through. We're taking more enforcement action than we've taken hitherto. With special measures, that means that we are committed to revisiting within 6 months. We would have revisited anyway, but the special measures regime says we revisit within 6 months. And some teams have higher levels of enforcement activity than others. What that then means is that their ability to do the mainstream programme is affected because there's more enforcement activity going on. When we did the modelling for the number of staff, we did make certain assumptions about enforcement activity. Some teams are under that, and some teams are over that in terms of the assumptions that are made. And as I say, then there are issues around productivity. So we do have data that we've gone through as a management team, and we're quite happy to share that and go through that in some detail. But they are the contributing factors to why there is risk in our ability to deliver at this particular point in time.
Yes, just to reiterate, we are going to be having a discussion of a recovery plan. It's a draft plan. That's why it's not in the public board meeting, because it hasn't been approved yet this afternoon. So unless there's something that's, on colleagues' minds that is not covered by this afternoon's report. Kay.
Yeah, I wanted to ask about registration, because we've talked about inspections, and there are also some sort of performance issues there. I think it's probably related to the new models of care. I don't know if that's all the reasons or if there's another reason. So I'd just like to kind of understand the reasons behind it a bit more clearly, and what we're doing, if you like, to just try and get it back on track.
Thank you. Thank you, Kay. Yes, we have been doing some work with the team to break down the activity to a more granular level in terms of actually looking at what's happening and creating a new performance management dashboard for us internally in terms of monitoring this, because that's been one of the things that's actually been very helpful on the inspection side of things. And you're right, it's new registrations, and particularly the complex new registrations, which are proving to be tricky for the team. And extending the time out so that the percentage of kind of completion is not where we would like it to be. What we're also seeing is an increase in the numbers of refusals, and obviously, the 50-day timetable kind of takes you from beginning to end on the basis that everything runs relatively smoothly. But obviously, if we are refusing an application, there's a lot more process that goes through. People can appeal against that. So that's taking time out. The areas which are much easier to handle, cancellations, the performance of those is better. So there's a kind of getting underneath the figures much more to understand much more what's going on, and identifying what are the issues that actually take us beyond the 50 days specifically, and some of those will be entirely legitimate, and some of those will be about improvements that we need to make. We've also been recruiting to the registration team, and we've not been at full complement, and we've had some turnover there as well. So some of the issues that have affected us in inspections have affected us there. And the third issue is that one of the areas that we really do want to get into is actually streamlining some of our processes around registration, and working with people in Paul's directorate, both from a policy point of view but also from an intelligence point of view, and working with our legal colleagues in Eileen's directorate to kind of, we've added lots of things to the registration process, making it robust and rigorous, but some of that, frankly, we could do with stripping out. So that's a piece of work that we're also trying to say, so we can actually improve the ability of the registration staff to handle things more quickly. And we are seeing a lot of applications coming through. That is the other thing. So part of the registration improvement project work, which is to have people apply online, so that the information that comes through, we filter out before it even gets to us people who are not filling out the form properly, so that kind of reduces the amount of time that we take going backwards and forwards on things, because you can manage that much more effectively online, and we're expecting to implement that from the beginning of November, but also to put much better information on the website, so that people who are applying to register new services or make variations are much clearer about what it is that we're expecting, what they should have to hand to support their application. So again, we can speed up the process and reduce some of the to-in and fro-ing.
It strikes me that registration, maybe we sort of brush over it a bit, but there are also some kind of important things to learn about, who is registering, the types of services that are registering or deregistering. Let's just say kind of wider things about how the sectors are developing. So just
yes,
a comment
and that's one of the things that we picked up in State of Care was the deregistration of, for example, the medium-sized nursing homes, and increased numbers of registration of the larger-sized nursing homes, and sort of thing, which of course is a wee bit of a worry, because what we've also said in the State of Care is that the larger nursing homes have poorer quality compared to the medium and smaller nursing homes. So I think that you're absolutely right, Kay. I mean, registration is the first and fundamental starting point for our operating model for everything that we do at CQC, and drives an awful lot of the information that kind of flows through into inspection, but also into our understanding of what's happening across all three sectors.
Thank you, Andrea. Again, as we will be coming back to this during the second half of our meeting, unless there are any other questions now, David.
Okay, thanks, colleagues. So moving on now to just reinforce recruitment. We're currently at 563 new inspector appointments offered against the 600 by the end of December. We've made 81 inspection manager appointments, and at the bottom of the page you can see that we continue to make offers in relation to analysts as well. The detail across each of the sectors is contained in those paragraphs. Once colleagues have been recruited, then the Academy has been delivering both the induction to the organisation, which is now a one-day programme, which is a kind of welcome to CQC, and we set out values and some practical information and knowledge about who we are, where we are, etc., what we do, who you need to speak to about a whole range of issues that you need. But then the important bit for inspectors is that the induction programme, the specific induction, role-specific induction programme kicks in, and it's that induction programme that gets people good to begin to start working operationally alongside colleagues, and then working independently as they move forward. So that continues to work effectively. In addition, training's offered in relation to things like mental capacity, which is an important issue, I think very complicated in many respects, overcomplicated, to be brutally honest, but to ensure that people across the organisation have got some of those practical skills. And for the first time this month, we're using the report to update on some specific training we've procured for Paul's strategy and policy colleagues in the main, which allow us to attend to the skills and competencies of those colleagues who are working for us. On the top of page 5, and just drawing attention to, because I think it's worth just drawing this out, that with the government's announced crackdown on illegal workers, which has been featured over the summer and early part of the autumn, CQC has been working and will continue to work with some of the Home Office staff that work in this area. One of the risks in the care home sector in particular, but not exclusively care homes, has been illegal people working illegally in England, and they gravitate to the low-paid sectors, and one of the low-paid sectors is care homes. And there are investigations, if you wish, inspections that take place with the Home Office, and where they are targeted at care homes, which they can be, they will then pass that information to CQC, and CQC may well be, CQC colleagues may well be involved in action in relation to ensuring that the individuals in those care homes are safe if there's a particular issue in terms of the future viability of a home because of the proportion of people who are working in those homes who are not supposed to be. We've got updates which I'll not go through in terms of additional information in relation to each of the 3 inspection directorates, which just give you an update on concerns which really have arisen through the work. So it's more the individual stories behind the performance data. Andrea's already touched on the State of Care report, which was launched last week. So I think if I may say, Michael, I think a very, very good report. I think rich in its content, and I think reflects a team effort from across the organisation, whether that's inspectors that have generated the information from inspection, people that have done the analytics to draw out some of the correlations, some of the people that work on presenting our information. I think been a number of favourable comments about the clarity with which tables and statistical information has been laid out, the infographics, etc. And then I'd like to think a successful launch, both on the day but also subsequently, which is a tribute to communications and media colleagues that helped to make that a success. Whilst the message was really about acute hospitals and safety last week, I do think this report will endure and be used beyond the day because of the richness of the information. So very little comment on adult social care on the day it was launched, but if you go in and read the sections on adult social care, I think there's some profound and important things being said in there which I hope can be used to inform future discussions about how quality is taken forward and driven. So certainly I think we all have some responsibility to make sure that some of those messages are out there, and it really is a tool for improvement. And then the last thing, although it's not in the report, the National Audit Office, if you recall, paid us a visit in the early part of this year. They published their report at the beginning of the summer. The Audit and Corporate Governance Committee, chaired by Paul, at the beginning of October, received the report from the NAO and also received the action plan of what we're doing against each of the recommendations. So I got the delights of the letter inviting me to the Public Accounts Committee next Wednesday, so there'll be a discussion at the Public Accounts Committee against the recommendations in the report, but I guess based on my experience of previous Public Accounts Committee, it will be any questions on quality and safety in health and care and any questions related to CQC. So new committee, new chair, number of new members of that committee, but a number that were members of the Public Accounts Committee previously. But that will be an event next Wednesday afternoon. So that's it, Michael. Thank you.
Thank you, David. Colleagues, any questions for David? Lewis.
My questions are really for the Chief Inspectors, if that's okay. But can I just first of all mention the State of Care report, which I thought was a really good report, one of the best things we've produced, I would say, and was quite well received. Once the press had got slightly over the issue of whether most of the health service was unsafe, some of the subsequent reporting was really very balanced and brought out some of the positive messages in the report about staff working very well under quite difficult circumstances in many places. I thought it was a very good report, and I was impressed by how some of the analysis of it was very objective out there. But I want to ask Andrea and also Mike something, if you don't mind, because since we last met, there have been two very important individual cases, so to speak, have been high profile in the publicly. The first is the inquest into the death of Conor Sparrowhawk. And just to remind the board, Conor Sparrowhawk was a young man with learning disability and autism who was in an assessment unit in Oxford, subsequently closed actually, and he died by drowning in the bath. I won't give you the entire story, but there was the inquest reached the verdict that neglect had contributed to his death. That was the key thing. Now this is important to us because every now and then a case happens. I don't mean that's in an impersonal way, but a person has an experience. A person dies in this case in a way which should influence all our practice and in a very comprehensive way, the way that we work. And this is a case of that kind. And I suppose I'm looking. I'm sure you're already thinking about this, Andrew, because I know you're very concerned about this case. But I'm looking for reassurance that we will draw the broad lessons from it, and that's because the broad lessons go beyond the individual circumstances of what happened. They are also about the standards of learning disability care that we're prepared to allow, the models of care. They are about the way that we in future will operate duty of candour, because although duty of candour did not exist when this death occurred, it would have been very relevant. How we in future will exercise the fit and proper persons regulation, because the coroner made some serious criticisms of the trust and how it had dealt with the family and the way that it had given information or not to the family. And then there's the broader issue of how carers in the system are sometimes treated, which, when we come to rating how caring or responsive a service might be, we should be taking into account, because in this case there is plenty of evidence, I think certainly plenty of discussion about the way that Conor Sparrowhawk's family were treated. Incidentally, Conor Sparrowhawk's mother, who deserves an enormous amount of credit for the strength that she's shown in pursuing the truth in this case, helped us in one of our conferences. She was a speaker, a very powerful speaker at an event that we organised. I chaired it, we hosted it, called the 3 Lives Report. But you shouldn't have to have that degree of strength and long-term fortitude to get the truth of what happens. And so this is a really a sort of pivotal case for us with widespread repercussions. And whether we do it formally or not, I just would like some reassurance that we will understand how important this has been to what we do and some of the responsibilities that we now have. I could stop there, but I want to ask Mike something as well. I'm sorry to hog the microphone for a second, but I want to ask Mike something.
No, Lewis, I think it is very important. Of course, I think in this particular case, Conor Sparrowhawk had epilepsy, and it was the lack of monitoring of him while he was in the bath. And in fact, I think it also said in the coroner's report that he liked to have long baths, so the need for monitoring should have been even clearer to the home. As I understand it, Mike actually inspected, or I don't mean Mike personally, but Southern Healthcare came under the Hospitals Directorate, and we did rate Southern Healthcare as inadequate.
I think we rated it as requires
improvement.
Okay.
So maybe we can, I don't know if we could start with Mike from the hospital's inspection point of view and then go to Andrea.
Because Andrea has taken a particular interest in this case, but we certainly have inspected Southern Health subsequent to Conor Sparrowhawk's death. I think it does throw up a huge number of issues, and we are, I can assure you, Lewis, taking this very, very seriously indeed. And indeed, within CQC, Paul Lelliott is taking a lead on learning disabilities, and we had a discussion only 2 days ago at ET about learning disabilities and how we're looking at models of care. Should we be registering things that we don't think conform to a good model of care? And I'm sure we will bring things to the board in due course on that. I agree with you, it throws up things about duty of candour, which obviously wasn't in place then, but we are now inspecting duty of candour on all our comprehensive inspections, and we will also, if we get concerns about a duty of candour in an individual hospital, that might prompt us to do a focused inspection specifically of that regulation, or indeed of fit and proper person. So the way we do that on our comprehensive inspections is that we are now asking to see a sample of the incidents that have been reported, first of all to check that they are assigned the right level of severity, because in this case it's clear cut that it ended in death, but in other cases things might be recorded as being only of have had mild harm and sort of moderate or low harm. So we need to be checking those. We also then need to check those that have had the right level of harm to make sure that the proper processes have been through. So we are doing that already, and I think we are frankly getting better at doing that as we go on with time. So all of those things are true. I don't know if Andrea wants to say anything specifically about Conor Sparrowhawk.
Andrea.
Yeah, thank you, and thank you, Lewis, for raising Conor today, which I think is actually really important. Most of what I would have said Mike has covered, in the sense that Paul is leading on the Learning Disabilities Programme Board, which has input from across the organisation, because I think you're quite right, some of the lessons from Conor's experience and his family's subsequent experience are very important for us in hospitals, primary medical services and adult social care. So I think that sitting it within the Learning Disabilities Programme Board is the right and proper place for us to do that. I think that one of the things that I've said about this is that we're very clear that the responsibility for improving services rests with the organisation that is delivering those services. And but sadly, Conor's death kind of throws up the fact that actually inspection and regulation is also necessary. He died in the July, we went in the September, and issued 10 warning notices at that stage under our old regime. So I think that lessons were not immediately learnt at that point, and I think both you and I would probably agree that there are subsequent lessons for the wider system as well as the individual trust to learn as we go forward. I've also met Dr. Ryan. She's an utterly remarkable woman, but you are absolutely right. She should not have had to do what she had to do to get to the truth.
Lewis.
There was another important case since we last met, and that's the closure of Bootham Park Hospital in York. So just to remind board members, Bootham Park was under the trust which provided mental health care for Leeds and York and the surrounding area. And it was closed because of long-standing safety concerns, particularly relating to the physical environment. Patients had, it was partly about ligature points and therefore the risk of suicide by hanging. Which has been a long-standing, I mean really long-standing, because the first government edict on this was in, 2000. So this is not a new issue, but it was still being addressed, and or at least not being addressed. It was still commented on in our report, I think in February 2014, on this hospital. And and then it came to September 2015, at which point by which time the service in York was being transferred to another provider, and therefore the provider had to be re-registered, and CQC felt that it could not re-register a service with these unresolved safety concerns about the physical environment and specifically about ligature points. Bear in mind that patients had died in this trust as a result of hanging from ligature points, but it still caused quite a lot of local concern. And there was quite a lot of the press coverage saw CQC's action as being rather sort of abrupt, despite the fact there was a 19-month lead-in period since our previous report. It was seen as rather an abrupt action taken without proper planning. What I know about this case, I'm not in any way subscribing to that point of view, for reasons which I've made obvious. It is astonishing that the problems hadn't been properly addressed in the time that was made available. But I still think that we have a responsibility to look at our role and look at some of the timings. So without any criticism of what we did, I want to make that clear. I just want to ensure that we are reviewing some of the timescales. I suppose you could say, why was it that it was September 2015 before this action took place, given that our first report saying that it was the physical safety was unacceptable was in February 2014. Now, the culpability there may be shared, but I think we just need to be clear, was there anything earlier that we should have done? And then when we inspected on September the 9th and 10th, I think it was, the closure, so to speak, became a reality in the final week, I think, of September, or more or less. There was a sort of gap in between the inspection and the decision not to allow re-registration. So there was a question about whether we acted as quickly as we could during that period. And then when it came to a lot of the local press coverage in which CQC was a sort of villain, we were left, because we hadn't published our report, we were left to say rather general things like, we wouldn't have done this without very good reason. Whereas in fact the reason was really more than very good. It was a matter of safety in a place where people had died. And yet it seemed that we were held back from explaining that to people locally because we hadn't published our report. Now that didn't seem quite right to me. And so I just would like, Mike, you may not have all the answers to that now, Mike, but whether we will, my question I suppose is, will we review how we handled Bootham Park, given the degree of local concern that it caused, with particular reference to some of the timescales and the statements that we were able to make at the time?
Lewis, I'll do my best on what I know of the timings. In fact, the Trust itself had identified ligature points as being an issue as far back as 2012. We had confirmed that on an inspection in 2013. We re-inspected it at the end of 2014 and published our report in February 2015. And as you rightly say, in that period there had been a suicide. And in that report in 2015, we made it extremely clear that action had to be taken, and there was an action plan from the Trust, Leeds and York, which was then running Bootham Park, that said that this would be completed by September 2015. That's why we inspected in September, because that was the time scale it was going to take to make the alterations. Remember, this is a Grade 1 listed building, and English heritage come into this, so it's a complex picture. It's 200 years old. And now, should we have said that's got to be done by July or August so that we could have inspected a month earlier? Quite possibly. I don't think we knew it back in February 2015, when this action plan and the timescales were set out, that there was going to be this transfer of responsibility for Bootham Park from Leeds and York Trust to Tees, Esk and Weir. So that we weren't aware of, and I think it was a collision of those two timings. But I think, in answer to your specific questions, yes, we should review two things. We should review the timings. Were those reasonable? Could we have inspected any sooner? When we became aware that there was going to be a transfer of that service, could we have been more alert and actually said, watch out, this will not get through re-registration? And that, we can look at again, and I think the issue of communications, and I think there can be some occasions where we need to be publishing an urgent report and making that clear. Even if the full report isn't by that stage available, we should be saying, and the ligature points have not been dealt with. So I think we can learn lots of lessons from this.
Can I just very briefly? That's absolutely right, but that is what I'm getting at, that whether we should be prepared to say something in more detail when an issue is already in the public domain. It's one thing to say, well, we don't give the full details because we haven't published our report yet, and there's a process for that. But once there is discussion of the case publicly, I think we probably are in the position of having to say a little bit more than, we wouldn't have done this without good reason. And I think there was very good reason. I just want to make that clear. There's very good reason, and it would have been helpful, I think, if we'd been able to be explicit about that.
So, Lewis, thank you for asking that, and I think Mike's covered it well. You are right, we do need to say something. We painted ourselves in a corner in relation to this, and very interestingly, I spoke to the Chief Executive of TZESC and Weir and explained what we'd done and why, and he was very open to the reasons why we'd taken the decision that we did, and this is somebody that's been working in mental health services for a long time, and he was absolutely clear about the unacceptable standard that was in that hospital, and we worked through with him, and Mike and the team worked through that. Yes, on Monday of this week, Paul Elliott, the Deputy Chief Inspector, and Jenny Wilkes, who was the Head of Inspection, who actually has been managing this process, who I think has done very, very well in relation to the difficulties around this issue, attended York Overview and Scrutiny Committee. They got 2 items on the agenda. One was our inspection of the acute hospital, and the other was our inspection of Bootham Park. They did not consider the inspection of the acute hospital because all the meeting was given over to understanding the issue around Bootham Park. The consequence of that is I think there was a different set of media coverage that existed following that meeting, where when the story was told, I think this is to your point about getting our message out sooner, people began to understand. NHS estates were there, quote unquote, this building is not fit for purpose. That wasn't the story at the time, but that's what NHS estates were saying. The clinical commissioning group, who changed the contract from Leeds to Tees and S Valley, were there, and they said why they'd done that, and also made comments about this. So I think what happened on Monday, interestingly enough, as a consequence of Overview and Scrutiny Committee, is that the story came out. I think there is a really important message which you're picking up on about we shouldn't wait for a public meeting in a council Overview and Scrutiny Committee to get our message out about what happened. I think there's also an issue, though, about why we are the lightning conductor when we said, I'm sorry, this is not good enough, and providers and commissioners can remain silent while that goes on, instead of people saying this is not acceptable, and the unacceptability of that came out when they were called to account in an Overview and Scrutiny Committee. So I think there's more than just should we get our message out early. We should. You're absolutely right. But there is something about others need to accept their part in how those services are re-provided in a more humane and appropriate setting than that which I think was offered there. I think Mike's point about the confluence of a change in contract from Leeds to TZESC and Weir at the same time that we were re-registering, and I think that's the issue where we could have been more proactive, saying we've got concerns about whether this is fit to be registered. So I think that's just 2 learning points. That point on registration, and then secondly about getting our story over.
Robert.
Just a point on the safety aspect of this, and it seems to me to have been a theme for a number of years, and this is not a CQC point, but about the system, that safety concerns have been addressed by the production of an action plan, and people are reassured that because something may be happening within a period of a year, then that's fine. When actually the implication of, say, ligature points, but it's not the only example one can think of, is that for the entire time that those ligature points are there, patients are at risk of serious harm or death, unless effective mitigation and protection is put in place, while the understandable time that's being taken, say, to do building works happens. And I just wonder whether, and I'm sure we do, but I'd like some confirmation that when we find something like that now, ligature points, that we not only say you must fix it and you must fix it within a year, but that we are satisfied that whatever protective steps are necessary are being taken, which could of course include not using particular premises until those things are fixed. It's obviously one has to be proportionate about this, and obviously the responsibility for that protection lies with the provider. But once we know about something and the gearing required to have a focused re-inspection, or whatever one likes to call it, may be too late. So I just wonder what we do about something that is called safety for a reason, which is that people are potentially at harm, and whether the system, and it's not just us, looks as though it's tolerating something which it shouldn't be tolerating.
Robert, very important point. I can't remember the detail of what was said about mitigation in February of 2015, but I will go back and check on that in the case of Bootham Park, because I'm quite sure we did make some comments about what steps they should take on mitigation. But equally, we often go beyond that, which is to put conditions on their registration until they have made those changes. So it could be that certain parts of the building might not be used if they're not under direct observation, for example. In the acute sector, we may say that some beds on a ward need to be closed until such time as modifications have been made, whatever. So there are a variety of different actions. One thing I can say is that where we have rated something, or are going to be rating something as inadequate on safety, we hold a management review meeting within a matter of a very few days to see what extra enforcement action might be appropriate in the individual case. And we do that after each of our comprehensive inspections, and where necessary after a focused inspection.
Jennifer.
I'm just wondering how good our intelligence is of all the possible changes in provider, where certain providers move from one trust to another, whether it's acute or mental health or community. Because up and down the country, I suspect there's quite a bit of this happening, and so it's looking at that map alongside our timing of our inspections, and so that in a sense, it strikes me we could be caught out again. If there is significant change requiring re-registration around the country.
Well, of course, the onus should be on the provider to be telling us when they are going to be changing who is running a service and therefore re-registering it. And they, there are timelines set out for how long in advance they should be doing that. I think sometimes they forget that, to be quite honest. I do think that's where the relationship ownership aspect of our work with our inspection managers and inspectors, knowing what's going on in a particular sector and being aware of that, can alert us to the fact that there is a change. So, and that is something that I think we can do better, and make sure that centrally we are then alerted to the fact there is going to be a major change of provision. I can think of one or two quite high-profile places that have been very late in telling us about a change towards registration. And I'm sure Andrea knows more.
Michael, if I may, I think it's a really important point, and maybe on the back of the experience at York, I might write to significant colleagues at a national level, just reminding them of the importance of being proactive where reconfigurations are coming through at an early stage. Part of, I think the point that you're flagging back, Lewis, is some of the change from the provider happened very, very late. So I think you've got the plate tectonics of two or three things coming together that have created this. One of them is a delay in people notifying us. I think you've then got reconfigurations going on. And to Robert, I think your point is, I think they thought re-providing the hospital is the way to address ligature points, not actually making sure that there was internal mitigation. I don't want to give the impression that they weren't, but I think you've got, actually the solution to this is a new hospital. And actually the solution needs to be both in the unit itself, and it does need to be re-provided. I don't think there's any doubt about that, but there's a medium and long-term solution, but there's some very, very urgent short-term issues that need to be addressed as well. And I think there's some of the lessons to take out. But perhaps we should write, really, because you're right, Jennifer, there's going to be lots of reconfigurations coming forward, and we should take the learning point from that. It's a really good point.
And if I may just to add, I think one of the critical things is for people to understand that registration is not an administrative process. There's actually, it's there for a reason, and kind of, some of the contractual processes are months in advance of the changes, but the notification to CQC is weeks in advance, and gives us very little time to do an appropriate and proper job. So I think, if we can reinforce those messages, that would be really very, very helpful.
Thank you very much. I think we can now move on to the next item on the agenda, which is the staff survey.
Shall I introduce this, Michael, while we're waiting for colleagues to come in? So this is a very important occasion for the board. We receive annually some information about our staff survey, which is a very, very important touch point for the organisation when we think about what we know internally in terms of what our staff are telling us, the progress that we're making, areas that we might need to think still more carefully about improving on, and to really focus on what are the key things that we can take from this in terms of learning and what we're actually going to do. I wanted to begin by actually publicly thanking somebody who's not here today, and that's Helen McNamara, who's our head of organisational development, who's actually just today gone on maternity leave. It's been Helen who, over a number of years, has driven, I think, great improvements in the work that we've done around staff survey and actually learning from it and honing the way in which we ask questions in order that staff feel that they can participate to their very best and make their contribution and have their voice heard. So Helen's done a great job there. But we have a fantastic team here who are going to help to talk to it and to assist in taking questions. We've got Samantha Holliday, who is with us and will be covering for Helen for a period of a year, and it's great to have Helen here. Quinton Manby, who is our relatively new head of internal engagement, and who is doing, again, I think, a fantastic job in taking the messages and thinking about some of the learning we need to do, because there is a key message about staff and how they feel that internal communications work. And then we've got Val Tor, who has been doing a huge amount of the work in terms of the practicalities of getting the staff survey out and encouraging colleagues to participate, and then working with our provider to make sure that we get the very best analysis out of it. I'm going to work on the assumption that you've all had the opportunity to look at the slides, which do set out the headline messages. And I think perhaps initially to invite Quinton and Sam to draw out some of those messages, and then we'll take questions if that's acceptable to colleagues.
Is that it? Yes. Okay. Sorry about that. Good morning, everyone. I just wanted to start by saying a few words about some of the highlights of the staff survey results that I've picked out, and then Sam is going to talk us through what's happening, what the next steps that we're taking. I think I'd start by saying that this is a very encouraging set of results. I'll spare the leadership team's blushes, but I'm relatively new to the organisation, and in my experience, these demonstrate that people are proud to work here, they're committed to what CQC does, and that the organisation is moving in the right direction. Not in every area, obviously, but generally speaking, that's what these results demonstrate. And I know the executive team are not complacent about that, and that there are things to work on, but all the things that we say need to be said in the context that these are a good set of results. So they're good if you benchmark them with previous years. 79% of comparable questions showed an increase, and engagement is moving in the right direction at 65%. And if you benchmark that against the wider civil service, that makes CQC a high performer, which means in the top 25% of organisations. So that's a survey that encompasses over 100 civil service organisations and is completed by around 250,000 people. So, and also, if you look at CQC and compare them against financial services, the health sector, as the survey company have done, they're also, we compare well. A fifth of the results are market leading, and a further quarter are good. So that, that is a good set of results. And a couple of things that I would pick out that perhaps you may not see from the headline results are are that in the area of equality, diversity and human rights, the engagement scores for all the groups that we identify with the sort of demographic results are very similar to the main engagement scores for the organisation as a whole, which suggests that those groups are as committed to the work of the organisation and feel as much a part of the organisation as the general population. And this is the first place that I've worked at that has that type of score. So I think that's very impressive. And it's an improvement on previous years. Virtually all of them have improved in terms of their engagement scores. The other thing I think is to say that the Hospitals Directorate has shown a marked increase. I mean, 10% increase in engagement from 60 to 70% is really, really impressive. That's a huge increase. And so, obviously, there are also other teams. If you look at the team results, we won't have that level of detail, but there's a legal team within corporate and customer services that has also had a significant increase in their scores. And I think when we look at the results, we've got a lot to learn from those people in the organisation who are obviously leading teams well. I think obviously there are areas where we could do better. One of them falls to me. So communication and the communication of change in particular, there are areas that are identified as underperforming. They're also identified as underperforming by benchmark, although actually I think it's part of a mark of CQC's success in the past in its communication of transformation, because those results were higher than the average, and actually what's happened is the results have dropped back to the average you'd expect for people's satisfaction with management of change, which is around 50%. And one communication area, strangely, has improved significantly. So being kept informed about matters that affect me has gone up 10%, which again is a big jump. So it is mixed. However, people do say very clearly to us that they don't feel that they're consulted on change, and they don't feel that they have sufficient opportunity to be able to feed in to change programmes. And so those are things that we do need to act on, and Sam will say a bit more about what we're going to be doing. Staff also say that and they have said in successive surveys, that we really do need to improve our systems and processes. They don't always support people to work effectively and efficiently, and that is very important. There are some other areas that we do need to investigate. So morale, I think it's curious that although people's personal morale, when you ask about people, they say, yeah, my morale is fine, or nearly 60% of people say that their morale is good. But if you ask them about the morale of the organisation as a whole, only 33% say that the morale of the organisation is good. So there's a disconnect there, and we should investigate that to find out what sits behind that. Also, bullying and harassment. It's still too high. It's moving in the right direction, but 11% is too high. And we've signalled that very clearly to people, that it's unacceptable. That's a very clear message that we've sent out to colleagues. And we will be investigating those particular areas more by looking at the demographics and seeing if there are particular groups or particular areas where that's more prevalent. So that's actually all I wanted to say. I'm going to hand over to Sam to talk about next steps.
Good morning, everybody. So there's going to be 3 areas of corporate focus. These are going to be management and leadership development, communications, which will link to the new engagement strategy, and systems and processes. But there are some other areas, as Quinton said, that we want to understand more about. So we'll do some further exploration work in the form of focus groups, which will take part in November. And these will focus around some key areas. So the first of those areas is wellness, which will pick up the debate around morale, harassment and bullying, and also pressure of work, which seems to come through in the survey. The second one is alignment of senior leader behaviours to the organisational values, and I know senior leaders are very keen to hear from their colleagues about what colleagues need to see, hear and feel from senior leaders in order that there is greater alignment to the organisational values. And thirdly, management of change. We need to understand what we need to do more of in terms of taking people with us in the future. So these themes will be picked up and explored in focus groups in November, and they will be independently run, and they'll be spread out across the nation so that actually more people have the opportunity to explore those themes with us. So the actions in response then to the deep dive work that we're going to do in November will form part of a further discussion with ET, and they'll be built into the business planning process. In the meantime, what I would like to say and celebrate is the organisation's appetite for the staff survey results has been high, and at the moment each directorate is considering their individual scorecards and having local discussions about where they want to focus their attention, and their actions are built into their business planning cycle. We also need to do some more cut of the data to now understand if there's any key contributory factors to morale, and also look at the results by grade and protected characteristic, which will form part of presentations to EDHR groups. So that's all I've got to say.
So thank you very much to Quinton and to Sam, who I think have given us a very good and clear explanation of the survey, messages from it, and the what next, which is very, very important, and we mustn't lose sight of that, that it is in the what next that the survey actually takes life. And I wanted to assure you that that's something that ET is very committed to, and through directorates there is a life being given to this in terms of the further look at data at a more local level, so that some of the differentiation that occurs understandably between directorates and teams within directorates is properly understood and can be taken up and worked with. But I think we've probably talked enough, and I'm sure you will have questions. So perhaps if I pause and invite anybody who wants to ask some questions.
Do colleagues have questions about the survey results? Kay.
Thank you very much, and I agree it's a very good result for CQC. We've come a long way. What I wanted to ask is this issue about management of change. I mean, the vast majority of people find change quite difficult. They respond differently. So I'm just wondering, what's the benchmark? Are there organisations that manage change well? Based on surveying staff, because I have yet to come across a staff survey that says the organisation manages change well, and I think, is it just? I mean, I say just, but is it not part of it, and probably a significant part of it, the fact that people are worried about change, and that maybe is quite a difficult thing to do well in that sense. So, do you know what I mean? Because it always comes up as change isn't managed well, and yet, I could say to you what good communication, involving people, and all that's part of change and good, a good way to manage change. But I think even if you get all that right, I still wonder what the results could be.
Because I think the problem for the staff inside organisations look to the leadership of organisations to run the organisation, the rationale for the organisation. Most of the change that CQC goes through isn't constructed by CQC. It's constructed by forces outside of it. And that's the main problem. And I think it's the main problem about the management of change, because actually the staff then feel that there's a bunch of people around this table that willfully are continually changing things, whereas actually the world out there is forcing the change on this organisation. Now, that's not. I'm not just saying therefore we despair, but actually, the reason for the change, which generally is to improve the health and well-being of the people of the country, needs to be explained as outside to inside to a person. The reason we're going to change your job is to make people safer, and not because of some internal gubbins. Right? And I think it's that thing. In the private sector, the reason we're changing is because of someone in China has changed the price of steel, and that needs to be, and that calls for leadership to be bringing the outside in all the time, rather than just thinking that the inside can, and using that as an explanation all the time. And that is quite difficult for leaders, because leaders like to think they're in charge. And actually, the point of what I'm saying is they're not, right? Because we can't be. But our staff want us to be, because they want that to happen. But actually, and so every time we say we're in charge, we undermine the real explanation that we're not. And I know it sounds, it is both humorous but incredibly real. Every organisation is being buffeted around by a bigger and bigger world, and everybody in that organisation looks to someone in charge to keep the world away from them, and that's not going to happen. So actually how we bring, because the point of this is in the next few years, there's going to be more change. So willfully, round the table, we're just bringing all this more, we will create integrated care. We will therefore create integrated inspections and change everybody's job willfully just after they've started doing the job. And until the outside comes inside, it looks like we're just making these things up.
I think that's really helpful, Paul, and in one sense we can have a giggle, but at the same time it is the lived reality. But as Kay rightly says, as human beings, the need to feel secure is a core attribute that makes our humanity for most of us. So I don't think it is all bad news. I'll ask Sam to comment, because she's just joined us from another very large organisation, so can offer, I think, a useful perspective. But we do have some slightly, not perverse, but indicators around how it's quite complex. So if you ask people about change in a really quite bald way, I think the answer's coming back, and we know we need to do more, and I think talking about why is incredibly important. But as Quinton highlighted, we've got a very significant uplift in the way that people feel that communications within teams and across teams is improving. And actually, when you're changing things, if communications within teams are improving, generally speaking, you're going to improve the way that you work with change. So we do have some more positive indicators around that, but not to say that there aren't things to do. But Sam, would you just like to comment?
Thank you. Just to go back to Kay's point, I think when you focus on change, people have always got thoughts and comments about how it could be improved, and certainly we've got to see this with the backdrop that Paul also gives us as well. So these results are not uncommon, I think, when you focus around change, and we certainly shouldn't be disheartened. The work that I think we should do now is look to organisations that are particularly good at doing that, to learn from them, and also to focus around what we can do locally. So when we speak to our colleagues, to understand what more we could be doing, and then to actually embed some of that type of activity. But like you say, we will probably not see results up in the 90s around organisational change, and we just need to be realistic about that, I think.
Paul. Thank you, Michael. Two things. First a question and then an observation. First, the question was about the overall response rate, and particularly the change in the population that there may have been over the last year. Because one of the things that I'm wondering about is whether the fact that we've had a lot of new people coming in, and therefore there's a change in the population as a whole. There may be some people who've had responses which they've made in the past which they just continue to make because it reflects how they felt for quite a while, and don't feel that there's been any improvement in that, whereas other people coming in new may have a different response because they haven't been around for quite so long. So I'm wondering if you're able to actually do anything to cut the numbers in a way which actually gives you what the effect is of that. And then the second one, the observation bit, is that when you look at, I thought the interesting part as well, one of the interesting parts about the slides was the things that people talked about in terms of starting, stopping or continuing. And there's a very interesting sort of graph there which shows that there's a lot of people saying a lot of little things, or a few people saying a lot of things, and a lot of people saying a few things. And the few things that they're talking about are about processes and about equipment, essentially, and that comes through time and time again, linked, I suspect, to workloads and stress and so on as well. And I think that is is very noticeable, and how we respond to that seems to me to be one of the, which would include change and all the rest of it. How we respond to those items seems to me to be the biggest thing that we need to tackle.
Shall I begin by responding, and colleagues can help? But to your first point, which is about cutting the data to actually look at the length of time that people have been with us. We did actually do that last year, Paul, and we will do it again this year. It was very interesting to see, because last year we did have a cohort of new colleagues with us, not quite so many, but a cohort, to look at the quite marked differences in terms of responses that came from people depending upon their time period with the organisation. And so what we'll be able to have on the basis of having done that last year is to make a comparison this year, where we've got still more staff who are new to the organisation, to actually see whether there are more positive responses coming at the beginning, whether you might get some levelling off after a certain period of time, and whether it actually goes up again if you've been with the organisation for more than 7 years, which was the picture last year. So we'll be looking at that just to see whether that holds good, because we can learn a lot from it, and try to build on what that offers us. I think what I'd started by saying I commended the way in which the survey had been conducted this year and said it was a developing process. And I think, Paul, you've drawn attention to the themes that we would start, stop and continue. And I think there's a great deal in there that is extremely helpful. We as an ET have committed to doing three things, or to focusing on three key things, which Sam has outlined. But looking at systems and processes and looking at where we can make changes, and remembering that when people talk about processes, they are not always talking about technology. They're just talking about the way that we organise ourselves to do things, the number of layers of complexity that we might put in. When David was talking about the improvements that are being made to drive up productivity, and talking about work in Steve's area, to actually look at templates that are used, that's a good example. It's not actually technology, it's just about rethinking the way we work, so that people can focus on doing the right thing and that process doesn't get in the way. And we need to do much, much more of that. In terms of technology, we know we have lots to do. We're also very realistic about the time frames that it takes to simply get to the starting line in the current economic environment in terms of making changes. But where we can, and if we look at things like IT equipment, which comes through as an issue here, what we're going through is a complete refresh of everybody's kit. So everybody will have in their hands a new laptop within the next 12 months, and a significant proportion of staff have that already. So we are listening, and we are trying to move forward, but we are also trying to be realistic about those things that we can do, and to get staff engaged in thinking about them, because actually around this table we cannot know every process that needs improving, and we need all colleagues in all directorates to be thinking about how, if you strip away some processes or improve them, we can actually become an easier organisation to work in, and a more productive organisation, and through that a more impactful organisation.
Thank you very much, Eileen. Can I suggest that because you are going to be holding these focus groups, and in fact, this other point which has been raised by colleagues, being able to run more, to use the jargon, more cross-tabs on this data, that you come back to us at our December board meeting for a further look at the staff survey results, and hopefully as a result of the focus groups and the cross-tabs, we get another, because I think it's one of these things where we have to go deeper, we get another layer of understanding. So thank you very much for this morning, and as I say, we look forward to seeing you in December for feedback from the focus groups and the additional tabs that we're going to run. Thank you very much.
Mark, it's just worth saying that because this is in public board, we'll now publish our staff survey. So just to reinforce that point, this will now go on the internet and it will be available for people to interrogate, and in a sense is part of the drive for transparency that we've got about just declaring what these results are. So we'll make sure that happens as well, just to reinforce that point.
Good. Eileen, are we going to, is somebody going to come in and...
Yeah, we'll move to the next item, Michael.
Yes.
I think I've got a couple of colleagues joining me, so we'll just let them get sat down. So what I'd like to do is just introduce the colleagues who've joined us. So we've got Tracy Forrester, who is the Director of Customer and Corporate Services here at CQC. And it is Tracy who actually heads up our responding to concerns work across the organisation. So she is the person who is actually tasked with taking this forward. And it's a very important and far-reaching role because it does touch the sides of every part of CQC. And we've got Jill Morrell, who's our Head of External Engagement, Public Engagement, I am so sorry. And Jill is working with Tracy because, as you'll see from the paper, there's a great deal here about actually the way that we present ourselves to the public and the external environment in terms of what CQC does and is able to do, which we believe to be very important.
Thank you. Perhaps we can focus, because I think it is the heart of this paper, the two graphics. The one on page 4 of the paper, which is, in a sense, about the reason why we want people to communicate with us. So if you can just take us through the thinking then, and I think as a board we need to agree that this is the right approach. And then we've got the second graphic on page 6, which are the, in a way, the principles by which the customer service centre is going to listen to people with concerns. So I think if we can focus on those two graphics, because they really are the heart of the changes we're going to make. Thank you.
Okay. Shall I begin, Tracy, and Jill, and then you can take over? Because I think you're absolutely right that we're asking the board to help the organisation to move forward in a way that ET has discussed and given a great deal of time to, and that's represented in two diagrams. I think it's also worth moving to look at the questions on page 4, which were the questions that helped to inform the process, underpinned by a great deal of research, which was just worth saying that when we look carefully at what we're doing and the way that we present ourselves, that I think it's fair to say that it hasn't been at all clear why we want people to come to us. We have not necessarily, and this is not just about the Customer Contact Centre in Newcastle, but across the organisation, not always had structured and reasonably controlled interactions within a framework that we readily understood. and that we are an organisation that has compassion in its DNA, but we've needed to think, what does it mean to be compassionate as CQC? And there has been very, very extensive and robust debate. This has been to Regulatory Governance Committee a number of times, so there's been strong engagement, and we've been grateful to non-executive colleagues who've given time to this as well outside of committee structure. And that has got us to what I think perhaps Jill and Tracy can explain in the first instance, which is an articulation of why we want to hear your information about poor care. So it's that actual external message that is so important in terms of setting the framework.
Thank you. Thanks. Hello. So in terms of the why, so as Eileen's set out, is the information that's been coming in through the organisation over the historical period of time has been rather confusing to members of the public, and our response in terms of how we've been handling that information of concern has been rather elongated or rather broad in terms of its context. And the piece of activity that we've been undertaking is to be able to crystallise the what is it that we want to hear from you in terms of information of concern. And currently at the moment, from members of the public, we receive certain types of information of concern, and where we've been working with this programme is to start to really think about if we are going to start to manage messages with our public, we want to be really clear about the kind of information we take in, and that indeed also questions a number of things around how do we start to understand that if we are to take the information in, how do we respond then in terms of the questions. So this particular diagram, which is why do we want to hear from your information, which is on page 4, talks about we would like to have a primary message, which is predominantly about making sure people get safe, effective, compassionate and high quality care in the future. And this is why we want the contact from the public. In the past, that particular message has been rather confusing in terms of, is this actually about high quality safe care and what do we do with that information? And that's been quite a confusion between how do we handle the information as well as how it comes into the point of entry into the organisation. But second to that, what's really important is we mustn't lose the secondary message, which is actually it may also benefit you and your family because of the information that you provide us with. And to date, where the confusion gets really, really lost in translation has been about the contact that we receive, has been predominantly about what am I going to get in return as a member of the public. So it's about trying to crystallise that message, which is very clear that it is in the first primary instance for the organisation to say this is why we want you to contact us, is because we want to make sure people get safe, effective, quality care. And then secondary to that, you may also benefit as a result of it, rather than it being the other way around, or indeed a hybrid approach to that.
Thank you. Can we just ask whether any of the board members have any issues with this? Really, as I say, summed up in this graphic, but the basis of why we would like the public to contact us. Are there any issues with this new way of explaining why we do want people to come to us?
Sorry, I don't know whether this is an absolute answer to your question, but I think this is a really essential piece of work. I'm really behind it, and I can see what lies behind it is a desire to clarify for people a system which is otherwise confusing, and to clarify our position in it. So that's absolutely vital and a very important piece of work. And I know in listening to what you've got to say that is what you're trying to get to. It doesn't at the moment come across to me that the main purpose is to help people. It sounds a little... this diagram is not bad. This is not a criticism of this particular diagram because it does have the word help in it. But there is a slight sense of something a bit more bureaucratic than helping people. this is what will happen to your contact, or when we get into some of the other things like this issue of compassion. When people talk about redefining compassion, I sort of feel we've entered a sort of bureaucratic twilight world that I don't otherwise recognise. And I think we've got to get the tone of this absolutely right. And the purpose is to help people who are worried about something to do with care and are turning to us as the sort of authority or the route into an otherwise bewildering system. And at the moment, I know that's your purpose, and I'm absolutely with you on that. I don't know whether that absolutely comes across at the moment. It's not so much about that diagram as maybe some of the other, some of the use of language elsewhere. On the other diagram, there's something about taking professional control. Now, I think I know what you mean by that, but I felt a bit uneasy about that being one of our key principles. Taking professional control sounds a little bit like we'll decide what you're really trying to get at here. I just think we need to be careful that ultimately this is about helping people when they're worried and maybe confused about what to do, or maybe have seen impediments in the system that they now expect us to help them get round. And that sense of helping people as our fundamental aim, I don't know whether it is coming across, actually. I have no doubt that is what you want to do, but I just don't know whether it's coming across. And maybe in the end, the documents will be better because they will give some examples. So you make reference to the Mental Health Act, for example. Maybe when we've got examples of how the Mental Health Act, how a concern or complaint about the Mental Health Act would then be dealt with, what it would look like, what people would do, or a concern in a care home, what it would look like, what we would do. And also how we would ensure that other bits of the system responded. So if we're going to pass somebody on, so to speak, what that would, how would we know that then it had been properly dealt with? Are we just moving the paper around, or are we ensuring that our involvement is a guarantee of that they will get the help that they've turned to us for? And so I just don't know whether that's absolutely come across. It sounds to me a little bit as if we're as keen to define what we don't do as what we do, and that will put people off.
Could I just respond briefly? I hope I don't occupy a twilight world, Lewis. Maybe that I do. When I talk about redefining compassion, it's quite simply that because we actually, I think everybody who works at CQC comes first and foremost that they are here to provide something for people and that it isn't bureaucracy driven. That actually what we have and have historically done, and why we have felt collectively it's important to say what we can't do, is that it isn't compassionate to give people a sense that CQC can do everything. And I think we've proven that that is the case, that we can't. So we have concluded that it's actually the most compassionate thing to be clear about what we can do and to also be clear about what we can't. And if we can pass people on, and that is in a supported manner, which we do already, is to do it better. But in the passing on, we cannot be absolutely certain that people will receive the outcomes that they want. But we will do our very best to make sure that the transition is a good one. So I think this work is underpinned by compassion and concern for people that they have a good experience, and a knowledge that actually, to date, with a level of confidence, we can't say that everybody does. Although everybody who comes to work wants to give people a good experience, actually the way that we have presented ourselves does set the organisation up to disappoint quite often, I'm afraid.
I think this is a good piece of work for the reasons that Eileen has mentioned. I think it's very important that people who approach us are given clarity as to what it is we do. And one of our problems in the past, and problems with people who approach us, is that they think we're doing something we don't do. So I think the first message is there has to be a positive one, which is thank you for contacting us. What you say to us will be of extreme value, not only to the public at large, but to you and your family in the future. I think that's absolutely reasonable, perfect message to give. As I understand it, the second diagram, which we haven't really talked about yet, is actually more an internal thing as a map for the staff to actually inform the way in which they actually construct a conversation, and therefore it's perhaps, I don't know to what extent that goes into the public domain. One thing I wonder perhaps could be emphasised more is that it is part of our role, it seems to be, is to receive the information to do the things that we say we're going to do with it. But whether we like it or not, we do have a role of signposting people or getting them to somewhere else. And I think we maybe need to explain that if they need to avoid the misapprehension, which I know we perhaps would like to do, but as Eileen says, we cannot necessarily guarantee that those to whom we refer, people to deal with their personal issue, will deliver the result that they want. But and it is not the CQC's responsibility, I'm afraid. Some might say it should be, but it's not our responsibility to make sure that has happened, except in very limited circumstances. And I know these are tough messages, but in one sense they're not of our making. They're part of what our responsibility is and what our responsibility isn't. And if we give people the wrong impression about that, then we're creating trouble for them, and we're not helping them. We're doing the exact opposite, would be my view. But I don't know. But I just wondered, as a question, if I can finish it off, not wishing to hog the debate, is to the extent to which we factor into this some clarity about, in both diagrams really, about what it is we do to help people go to where they can get the help that they also need for themselves.
I think it's important to say that the principles are now going to help us work out the language and define the language that we'll use. So they will underpin the language that we use, and we'll make sure that that language is encouraging to people. We'll continue to encourage and enable people to tell us about their experiences of care, and we'll continue to do all the work that we do to encourage people to do that. And the language will be encouraging, but what we want to do is make it really clear that it's to help prevent poor care happening to people in future, and to, as you say, to help you and your family in the future, and to be clear about where people can go for help. And I think that is a compassionate approach, and it's being clear with the public what they can expect from us, but that we do welcome that information.
Just one question before we go to Paul. I was slightly unclear about whether we have now trialled this new approach, or whether the trial is about to happen.
Yeah, so we have tested this approach with a very small group of our colleagues of inspectors right across all 3 inspection directorates, where we have been working with those colleagues in order to be able to understand the information that's coming in through the National Customer Service Centre, and then being able to make sure that that's really good, consistent quality before it goes into an inspector. And we've also took that a little bit of a step further, which is about helping our inspectors understand the severity of the kind of information of concern, and applying a new priority level system that actually supports our inspectors to kind of understand the sort of distinction between what maybe is of absolute significance for that day, or what maybe could be addressed in a different way through using other information. That's had a really good positive response, but before we proceed and roll that out even further, we wanted to come here today to understand the approach.
Sorry, well, I think that's very helpful, Tracy. I suppose my question was whether we've actually tested the new way of explaining why the CQC would like to be contacted, but also whether we've tested the 5 principles with live calls to the service centre, or whether that's the next stage of what we're going to be doing.
So sorry, I wasn't very clear on that last answer. The test of the small test group that we've had has been around taking live calls in from the National Customer Service Centre, as well as information that comes in the written correspondence form. And we've been rolling out that through a training programme that really helps us understand the type of, you talk about professional control, but actually it's about the type of information we want to be able to control in order to get the right information out to manage expectations. And then again, in response to signposting, we're not just stopping doing that. It's really important that we do that, but it's also about managing the individual's expectations so that doesn't continue a virtuous circle.
Can I just add, not to delay, but I spent some time last week sitting in Newcastle for another reason, but I was actually in proximity to the team that are part of that pilot who are taking the calls in. And I was just hugely impressed by the way that they are working with those principles. It comes across in a very humane, very caring way. But they themselves feel that they're getting better quality information and that people are having a better experience of actually talking to us and bringing something to us. So I think it's very encouraging. But they've all received training, and that is really what we're committing to here, if you agree, is to extend this and to develop it through actually getting more people trained. But it's not just, I would stress, in Newcastle. It is really across the organisation to think in slightly different ways about the way that we interact.
Paul.
Thank you, Michael. That's very encouraging to hear, I have to say. I was a little unclear on the diagrams, though, about the use of the first diagram, as to whether this is something which is meant to go out to the public or just to be internal.
Those are the principles that will underpin the language that we'll develop. So we're not intending on that being what the public will see. We'll develop message, web content, and change the share your experience form on our website to reflect those principles, but that's not a communication to the public.
I find that's encouraging, because it looked like we're going round in circles, basically. And I think part of it needs to be actually we're helping people go to the right place as well.
Yes.
Although, just to be clear, it is on the website already, so it's out. All of our papers are there today, so it's already generating conversation on Twitter.
Bless. So to your point, Paul, and if I may just pick up Lewis's point about professional control, and I think it's a really helpful conversation about how we take this and move this forward. I think the third point in the covering paper for this is that we'll now take this forward and embed this in the way that we work. But for 3 years, I've signed letters to MPs which effectively struggle with a sentence of, we don't consider individual complaints. I think this is to the point about it. So I think Jill's point is, what we can now get from these, from the diagram on page 4, is a narrative about why we want people to tell us about poor care and what they can expect us to do with it. Which, Lewis, to your point, there is in part here saying we are not set up to deal with, we do not have the power to do individual complaints, but instead of starting with what we're not doing, we're starting with what we are doing. So I think this gives us a much better set of explanations about what we do and why we do that we can explain. Because you've made this point on many, many occasions quite properly about people make a big investment when they come to us. The fact that they've picked up the phone or they've sent an email is a big thing. It isn't what most people do. And therefore we need to receive them in the right way and be absolutely clear to people why we're interested in their story and what we're going to do with their story or their experience. And I think of the testing, we feel that this is a better way of actually articulating back to people about why we want their story and what we're going to do with it. I think the professional control bit is more internal, and I'm sure you do know this, but again, a number of us 12 months ago went up to Newcastle, and I think you sat in and you listened to some of the telephone calls which were coming in and looked at the emails. And speaking to the staff that take these calls, they will have shared with you their experience. Some of these calls can last for 2 hours. And actually, the question is that a good thing for either the individual making the call and for the person receiving the call? I think they would probably have shared with you, they've certainly shared with me, they felt wrung out, is that what's my grammar? It's wrung, isn't it? Yeah, out after a call like that. So the issue is that what should we want to help? Should we listen to that, or should there be some sense of? So what you're telling me is this is your concern, right? What we can do with that is this. is really what taking professional control means. It means actively listening, but then being quite clear what we're going to do with that, and not letting these conversations go on for 2 hours. And 2 hours are the extreme. Don't get me wrong; they're not all running in that way. But when Tracy pulls off the performance data about how long these conversations, there's more of them lasting longer as people come in an absolute state of desperation because nobody else will listen. But we might not be the right organisation to help. You've already made the point about Conor Sparrowhawk and who was listening to a very articulate woman and how hard it was. Well, that's what those staff are dealing with. So I think help us with the tone and style of how we take this forward, I think, is what we'd say. But I think the principles are an internal set of principles about how the teams will work that. And I know, because I've listened to them, they've been using some of these principles in the calls. So to your point, Michael, they have been trialling these in the calls and taking them forward.
Robert.
Could I just add that, of course, the priority is the helping members of the public help us and indeed in the end help themselves. But in fact, going back a bit to the last item in relation to the staff, it's triggered by what David just said. I've talked to people in the service centre, and what's clear to me is that the potential for stress on the staff of this conflict, which I'm sure some of us feel when we all get letters too, of feeling we want to do something but we can't. And if you, at the end of a 2-hour conversation, that's the feeling of the member of staff, then that could easily explain some staff survey results. And it's not fair to the staff or to the public if we aren't completely clear what it is we can do.
Can I just say that is an incredibly helpful comment, Robert, and Tracy, I think, would reiterate that staff who've been trained in the new methodology feel that they are much better equipped to deal with the often very difficult circumstances that come to them. So I think we are seeing it from both sides of the coin. And to also add just one thing, which is where we want to get to, is from the inspector's point of view, the people receiving the information. We're very, very grateful to the inspectors who've given time to working with this, and in terms of understanding what they need to do their jobs and the levels of prioritisation that they believe should be assigned to things. And actually, those that are involved feel that actually makes them much better equipped to do their job, to respond in the most appropriate way, to take action much more quickly. And I think, that plays to other things that we've been talking about earlier in the day. So, there are many angles on this, which is why I began by saying that this is a programme that does touch the sides of every part of CQC.
Michael, do you mind if I just make one comment on that? The aims are fine. So debating the aims is not the issue. The aims of what we're trying to do is right. It has been a frustration for everybody here, I think, I've noticed over the last couple of years, that people expect certain things of CQC that we're not really equipped to deliver. In fact, they're not even in our remit. And so it's absolutely right that we try and do something about that. But there is a danger that that turns into sounding rather reluctant. And if we're not careful, we will define our role by what we are not prepared to do. And that's my worry. And so the tone of this, it's not about the aims, it's not about the need to define, or the need to send people in the direction where they can get the best help. But we can't turn our own frustration about the demands, the unreasonable expectations that are on us. There's a lot of reference to expectations in this document. It does feel like there's a sense that managing the expectations is in the end its main purpose. And that is a very short step from sending people away. And we just need to be careful. I don't say that's our aim, but we just have to be careful that we don't define ourselves by how we... because for that person who's worked up the courage and so on to contact us, the bit of our response that they may hear most of all is, you've come to the wrong place. And it doesn't matter what else we say, unless we're really careful that what we're doing is responding in a way which is about helping them. So getting that right is the issue, not whether we should try and do it at all. That's not the issue.
Well, that's a very helpful comment. I think we have the opportunity, because the board is meeting in Newcastle next month, and I'm not quite sure whether the programme for the board meeting has been decided yet, but I think another opportunity to to hear from Tracy, and perhaps for each board member to sit in on, a couple of calls, I think, would be very helpful. And it'd certainly be helpful to see if we can understand more Lewis's point, which is that we're a listening organisation, but we listen with a purpose. And we're not just about, although we call it a triaging process, and inevitably in a triaging process we do tell people we're not the right place to go, but that we do it in a way that is consistent with the aims of the CQC. So perhaps we can just make sure that when we're in Newcastle we have this opportunity to look again at some of these concerns that board members have raised this morning. The final point in the responding to concerns board paper is the progress with setting up the Office of the National Guardian. And Eileen, perhaps you can just give us a minute or two on that, although obviously it's out for consultation at the moment.
That's quite right. It is out for consultation, and we will obviously await that closes, I believe, on the 6th of December. In practical terms, the recruitment of the National Guardian is proceeding, and we will expect to interview for that role on the 27th of November and to aim to make a substantive appointment into it. Whilst we are in this period where we know the office is going to exist, but we don't actually have the Guardian in place, there is going to be the establishment of what you might call a shadow office, which is to put in place some capability for a period of about 6 months to actually have people in place who are able to respond to the consultation, to do some practical things about setting up the office ready for the Guardian to come into. It will then be for the Guardian to specify what the office should look like. We're very clear that whatever we put in place is actually a holding position, if you like, and that when the Guardian is then appointed, it will be then for them to say, this is what my office should look like, these are some of the capabilities I need, and it will be for us as CQC to support in that. But it will be 27th of November, as I say, when we very much hope to be able to make that appointment and to move this very important agenda forward. But I don't know if Robert wants to add any.
No, I'd just say that the recruitment process which I'm engaged in is promising. I don't think I can say more than that at the moment.
Are you talking about the appointment of the Guardian or the person setting it up? Because there's two positions, but you're actually talking about the National Guardian role, are you?
So
and that's open recruitment, is it?
So there's been national open recruitment for the National Guardian role, which is where Robert says we have promise. What I was talking about in terms of shadow format is really the issue or setting up via six-month temporary contracts of the capability of an office to deal with a consultation and just get some practical things done, Kay, which is why I say we want to leave the latitude open to the Guardian to actually specify what they want to do.
Thank you very much. Well, thank you for coming to present the Responding to Concerns programme. I don't think there can be many programmes of equal importance in the CQC. And I think from listening to the board members, I think there's every encouragement for you to embed this new approach. And as I say, we've got the advantage of being in Newcastle next month to perhaps have a practical demonstration of how this approach is working. So thank you very much for coming this morning. Paul and Steve, we're now going to move on to possibly a less pivotal but equally important subject, perhaps, of our new dental services program board and how we're going to be taking forward our program of regulation of dentistry. And I don't know if there's colleagues who are going to be coming in for this. No. Right. Well, is Steve or Paul going to take the lead in taking us? I think you can assume that all of us have read the document, and especially the objectives in the document, which I thought were very well articulated.
So Steve and I are doing a double out on this and the next paper. So Steve's going to lead this one away, and then I'll lead the next item away, if that's okay.
Thank you. It demonstrates CQC working together across the directorates, and it is a real joy bringing what will be a pivotal paper, but something that's not on general practice, but on something which is equally important to me in my directorate, but actually by volume is greater than general medical practice, even though by volume of words we spend more time on general practice. And I'd like to credit Janet Williamson particularly, but also in Paul's team, Amanda Hutchinson and Claire Robbie, that work together as one. But Janet has taken forward our regulation of dental services, I think with great skill, to a point where actually there is a lot of harmony between the regulators and providers. And this paper is work in progress. The Regulation Dental Service Board was established a year ago now and is working very well. And as you said, Chair, the objectives are very clear in the document, but I think this is a great example of how the regulators can work together with NHS England to try and put some sense into what is quite a complex area, and the feedback from the service and from the union, the BDA, is very positive. And part of the reason behind that is that we hired John Milne, who used to be leading the British Dental Association as our national advisor. So we've got a really strong dental team. The policy team is excellent working with them. I don't really want to say more. It's just that we would appreciate the endorsement of the report and the ongoing work by CQC Board, because it's very important to us.
Thank you, Steve. Thank you, Steve. Our board colleagues happy to endorse the work that's encapsulated in the report. Kay.
Yeah. Thanks for the paper. I mean, I was kind of struck that there didn't seem to be much of a patient voice in this. I know you've had some input from health watches, which was largely around access. And I suppose from a sort of patient point of view, you want to know if a dentist is safe, but you'd also want to know if it's any good, and there's no way of knowing if it's any good. And so, I mean, it may be that because the dental sector is relatively low risk, that we're not giving it the same attention and approach as other areas. But it feels it's more this is for the regulator and for the dental sector, and less for the patients and the public.
Thank you. I mean, I think it's similarities to general medical practice, and how do you get information from the consumer, the patient, with similar challenges. So our engagement teams certainly are working on that, and Health Watch, where it works well, are engaged. But I'll feed that back to Janet. And but it is something we're taking very seriously. Yeah. But it is different to when you go into a
Well, I know. I mean,
hospital.
I recently had quite a bit of dental treatment, and they gave me this survey thing, but I didn't fill it in because I didn't think it provided the right opportunity for me to give back, to give feedback. And I wasn't that impressed with the service I got, but I have no idea whether it was good or bad or middling. So I just wonder whether we are doing enough to get to what patients and the public might want from.
So what we're so as you'll see in the table, NHS England are taking a lead, particularly on that area for us. I think there are lessons from here to general medical practice, because the issues actually are very similar. And you say low risk, but there are risks in dentistry, particularly in sedation, and particularly then when you move on to implants and other areas. So we're not complacent in any way, and I think this is something I'd like to replicate in medicine. And indeed, we've started doing some work with the GMC and NHS England on looking at how we reduce bureaucracy from the regulation and contract managing process. But you're absolutely right. But if all of the organisations are trying to get feedback from the same patient groups, there's a danger there. And what we're trying to do is coordinate our activities. But I'll feed back your concern to you, and I'll try and get some more detailed feedback from where NHS England's on this, because they're the ones who are actually taking this bit of the work forward.
Thank you very much, Steve. Any other?
Just one question. My understanding, correct me if I'm wrong, is that one of the features in dentistry is that it is not increasing, but there is an increasing presence within the field of more corporate-style organisations who employ dentists on a sessional basis, which leads to potential issues of not only professional but other forms of accountability. And I wonder to what extent this programme is taking that into account and how the challenges can be met, because although in one sense it is a field like general practice, it also has some of the aspects we see in the care sector.
Thank you. In fact, they're ahead of general medical practice on this. Over the last 6 months, lots of GPs have been merging in different legal forms. What we can see from some of the big providers in dentistry is that they have very good governance procedures and also quality initiatives with dashboards. And we're finding in general medical practice that big groups are going in that direction as well. And so, and they're better at, going back to Kay's point, getting feedback from consumers, and are more rigorous in feeding that to the dentists, even though they might be on salaried contracts. And so I think I'm quite positive about the direction of travel, because both in dentistry and in general medical practice, the problems we see are about professional isolation and no contact between different groups. So we will also have to look at how we register those groups, because there's lessons as well. And as you say, there are big lessons from social care, which is why when we're looking at these bigger corporate entities, it's the social care team which leads on that, and we all have lead people from our directorates working with Andrea's team. So it's very important. Thank you.
Any other comments?
Michael, thank you. I don't want to prolong, but it's an important point about where the user perspective is, and Kay's question is a really important and a significant one. From my point of view, in 2012 there was no tradition of CQC working with the GDC, and no tradition of CQC working with NHS England or its predecessors on the issue of dental regulation. So the criticism that CQC wasn't working collaboratively when applied specifically to dentistry applied to both the commissioners and to the professional regulators. So this board was created to make sure that we were working with the GDC in terms of their professional regulatory responsibilities, and also trying to be absolutely clear with NHS England what their commissioning responsibilities were around the quality of practice. And when I said there was no tradition, I don't think there's any history of meetings where 2 of the 3 came together, sat down and had a conversation about what they were going to do. They kind of existed in splendid isolation of each other. I think what Janet Williamson, and I give her huge credit for this, has achieved is bringing people into a process and around a table with some pretty important things about how the commissioners, the professional regulators and the quality and safety regulator work together to come up with something that is coherent. And I think the fact that this has been this document has been produced, its focus is regulation care. I think your question is still appropriate. I think is a significant development, particularly on this issue, the question which we've debated previously here, which is how do we relate to the professional regulators, where does their role begins and end, and where does our role begin and end? And I think the focus of this work moving forward is to remove any potential duplication that exists between CQC in terms of our responsibility for the quality and safety of general dental services and also what some of the professional regulators do. So I think it's an advance on the absence of any glue that binds this together, but there's still a lot of work to do. So whilst Janet, I think, has been outstanding in the way she's drawn this together, with Amanda Hutchinson and John Milne as well, really this sets the baseline from which the further work needs to go. So it's the development and application of this which is significant, although it is a pretty impressive milestone that Janet's got us to with this.
And you can see therefore the advantages of what we're learning for general medical practice, which has been in a similar position, albeit that NHS England is new to the party. And CCGs are now even newer in their commissioning role, and the more we can avoid duplication and work together for patients, the better. And as David said, Janet has been an absolute star in leading this work.
Steve, thank you very much. Can we assume that well, I think this is really just for noting, but that the Regulation of Dental Services Board, Programme Board, and the document have been approved by the board. And I think, to take Kay's specific question, I think, as it happens, the last area of improvement in the document is about patient communication, and it says that there will be doesn't exactly say what the nature of the report back will be, but that the target for that is April 2016. And perhaps nearer the time we can come back to this issue of patient communication and whether, for example, to take Kay's point, there should be a different kind of national survey or some kind of way of understanding public satisfaction, both overall and with regard to particular practices.
It's worth saying on that the Friends and Family test went live for dentistry in April 2015, so that's rolling out. So I imagine it'll be one of the things. Yeah.
I didn't.
Not everybody does.
Yeah. Good. Now, Paul, can we move on now to integration pathways and place? And I think as I read this, the particularly important part of this is the thematic reviews we're going to carry out and the requests we're going to make of the Secretary of State to allow us to undertake 2 new Section 48 investigations.
That's right. So the purpose box on page 1 sets out the 5 things that we're asking for agreement on or to note. And I don't propose to go through those, but I think it might be helpful to give a bit of a context to explain why we're in the middle of such an ambitious programme. There are four elements to what CQC does, and Andrea referred to this in the operating model earlier. We have registration, we have the monitor, inspecting and rate function, we have the enforcement function where people fall below fundamental standards, and we have independent voice. Those are the 4 things that we do, and for very good reason sometimes we focus on the first 3 of those. But this is an opportunity to talk about the 4th and equally important element of CQC's externally facing work. We do talk from time to time about it. For example, when we published the Right Here, Right Now mental health crisis care report, that was a good example of a thematic which was a long time in the preparation, involved a good deal of work across CQC, but I hope colleagues would agree landed well and is contributing to changing that incredibly important agenda. As we pointed out, care is often unsafe, and that's unacceptable in the mental health crisis arena. So we've had a thematic programme for a good 2 or 3 years at CQC, and we launched a particularly ambitious programme which we've taken to the board for approval this financial year. It's ambitious in the number, and it's ambitious also because we wanted to focus some of it on the actions we were taking around shaping the future. So some of the work that we're doing is specifically around testing new approaches around pathways, place and populations. And that's very important that we do that as we look to get better at our current regulatory approach as well as shaping the future approach. We've also had requests in year, notably the data security review. There was a request from the Secretary of State, and that review is underway and due to report in January 2016. So the full timescale is laid out in the paper. What Steve and I, as co-chairs of the overall programme board, have been looking at is how deliverable is that programme, and what's the right balance between pace and risk of not delivering, particularly given our other regulatory commitments, including the work that goes in from inspectors and analysts and other colleagues into delivering the rating function. And what we feel is there are two thematics that are listed there, where we should move the field work into Q4 and then report in the first quarter of the next financial year, rather than the original proposal of doing that work in this quarter that we're now in. That's the balance of risk compared to what we're doing. Will still be work that we'll report. Then there's finally one piece of work, which is the DNA CPR, where following the work that's now underway with the Resus Council, we don't think it would be appropriate to duplicate that work. So we want to use their findings rather than do a separate thematic. And as Michael says, one of the asks in this paper is around requesting from the Secretary of State the Section 48 permission. Just to remind people, we have powers to do these thematic pieces of work, but there are certain circumstances in which we have to ask for Secretary of State permission, particularly if we're looking into the commissioning functions of the NHS or local authorities. And it's something we have already done this year, for example, in the place-based work and the integrated care of older people. And we've received those acceptance from the Secretary of State to use the Section 48 powers, but we want to do that for both the diabetes piece of work and the urgent and emergency care for the reasons outlined in the paper.
Thank you very much. So I think it's really for the board to, as Paul said, to note this and to approve the request of the Secretary of State. There's also one other issue, which is all the thematic reviews now have a board sponsor, and which I think is admirable, except one of the two new ones, which is the urgent and emergency care. Now, as it happens, I'm not down as a sponsor of any of the thematic reviews, so unless another colleague would like to volunteer, I'd be very interested to be the board member sponsoring the urgent and emergency care review. So is the board happy with Lewis?
Just doing one point. I'm happy with the paper, yes, so I agree with that. I have sometimes had a slight concern about what I think you implied at the beginning, Paul, which is that this is sometimes fourth on our list of four. So that where it's not particularly a criticism of the system, but when time and resources are squeezed, that the sort of weak underbelly is some of the areas of work that we have here. So I'm involved I'm the board sponsor of a few of these pieces of work. The work on the Mental Health Act, for example, we've talked previously about how getting some of the information on mortality under the Mental Health Act has been delayed because for various reasons, and yet that is probably one of the most important things we could possibly report on, mortality among people who are currently detained, their liberties removed. One of the other ones I'm working with is the inequalities in end-of-life care, and that seems to have gone into a rather more protracted timetable than it was originally planned. And so my worry is that this is an area of our work that is quite easily squeezed when resources are tight. And that either means we should be more robust about defending it, or it means we should be more realistic about what we can reasonably take on and by what timescale. And it'd be useful to get your comment on that.
Thank you. I think there has been a bit of that in the past, and I think the response is both the things that you've talked about. As we bring the programme for next year, I don't think we'll bring as many separate things. I think we'll want to think carefully about where we can add most value and protect the resource to do that. But the second thing I'd say is that the Deputy Chief Inspectors, particularly Sally Warren, who's been coordinating on behalf of not just adult social care but working with the other DCIs, have been working really hard to make sure that the resources are available to do the work. Sally puts in the right challenge across the programme board that we need to make sure that we know when inspection resource is needed, as well as analytical resource and policy resource and engagement resource, so that everything comes together. The truth of this is that we are tight for resources, and we've highlighted that in the recruitment and in the earlier conversation about our inspection programme. But equally, these are important and they're complex, so they require an awful lot of things to come together internally and externally. And what Steve and I are trying to do with Sally and others' help is increase the grip, the sort of project management of each thematic, so that each thing happens when it says it will happen, so that we don't find things elongating unnecessarily.
Another way of looking at this programme is it is preparing us for the future, so that rather than just being a sort of an add-on, which in some way is an expensive add-on, actually I had a meeting with because I'm the sponsor of the Old Persons Pathway, and I just went through, and probably we are about 200 inspectors in the last few months have been trained in doing integrated inspections and are practically doing those integrated inspections. Now that is a resource we didn't have before as a result of this. And I think the likelihood is, and the likelihood not just in this country but across the world, the whole notion of integrated care is that this is going to be ramped up. And because of these thematic reviews, we find ourselves being better prepared for that every month. Not in an abstract way, but in a concrete way of actually we have now got staff who are not inspecting in the thing they're employed to inspect, and are learning to do this incredibly difficult thing of inspecting in the places they weren't employed. Now, across in the real world of care, not just the world of inspection of care, hundreds of people are learning to do that every day, and it's very, very hard. So these themes provide us with something to say at the end, but they also provide us, we are now learning how to do integration in the way in which other organisations out there are learning to do integration, and just how hard that is. So if suddenly someone says integration is the name of the game, we are getting prepared through this. And, hopefully, but, in a sense, as it ramps up, at some stage, this becomes the main game, and other things. And that is a 10-year programme, not just for us, but for carers. So actually, this is, I think, materially, I've got no doubt this will get resources, because it's the future.
Sorry, I was going to. That was a very real live thing when Mike and David and yourself and I went up to see Greater Manchester colleagues at the back end of last week. The fact that we are talking to Tameside and Salford about the place-based pilots that we will do in November of this year means it's a very different and real conversation than just looking from the sidelines of what's going on. So we're well prepared for the changes that are already with us in Manchester and elsewhere.
Jennifer, who we should also note is the sponsor of the quality in a place review.
Indeed, thanks. So only just to say, support everyone's comments and like it very much. Thank you. It looks good paper. Just a small point. I wasn't quite aware that I was the board sponsor of Hospital Investigations, which I notice is to be published on the 18th of November. So I don't know whether that's a typo error or whether I indeed am the board sponsor. So if you could let me know.
I think we better check.
Steve.
Just briefly, I mean, Paul's absolutely right. This is the way forward, and it's good. So having covered dentistry, we're now in the title of our directorate is integrated care, and we have a team there that are helping coordinate. And when you talk to inspectors, the new inspectors particularly that have been recruited, they're very keen to get involved in the joined-up care across health and social care. And in fact, in London, where we've had difficulty recruiting, and now thankfully it's the numbers are coming in, they're worried that they won't be able to do as much of this if we're having to meet the target of next September on GP inspections, because they see this as something really exciting. So when we continue to work on the strategy that Malta's leading for us, this, of course, is central to that and really very important. So it's lovely to have some time to talk about it. Thank you.
Good. I think this sounds like, Paul, that colleagues approved the programme and, I'm not sure technically how this happens, would like you to make the Section 48 requests. So we've now got two final items on the agenda. First of all, a report from Lewis on the most recent RGC meeting, and then from Paul on the recent audit and governance committee meeting. Lewis.
I gave an initial feedback just after the meeting at our last board. But it's worth saying that, and the paper's self-explanatory, the main themes of the meeting are in paragraph 4. And it's worth saying that some of them are already part of our broader discussion here. In particular, the inspection target. And at this meeting on primary care and on the previous one on social care, there was an almost perfect sort of fit of issues. And the inspection target was one of the main ones. And I suppose from my point of view, it was where I first became aware of the difficulty that we've been hearing about. So the inspection target was, I suppose, one of the dominant themes. But so are some other issues which now need a place for us to take them. So I suppose into our strategy work. For example, the very high number of practices rated good. So one interpretation, there is lots of good primary care. The other one is we're not very discriminating about what's good and not so good. And we need to get to a point at some time where we're better able to inform the public on which is which. So those are the main issues. I think there's one other thing, though, that I just wanted to highlight, and it fits in with Paul's comment about steps towards understanding integration or an integration model, because we did spend a bit of time talking about where primary care contributed to other areas of the inspection system. And saw that as a very important part of what it does or could do more of. My example at the meeting was about medicines management in care homes, which is something I felt strongly about for some time, because it's a very difficult thing for our social care inspectorate to comment on, because it's very much about the pharmacology of primary care. And so there's one area, but it's one of several, I think, where the beginnings of integration can be established, and I think we mustn't lose that. I think it is a big part of how our inspectorates should be working together. So
thank you.
Just actually from the last agenda item into this agenda item, it's going to be one of the 5 themes from the old person's review. Is going to be a joined-up look at medicine management between social care and
Paul.
Thank you, Michael. Again, I won't go through the entire paper. Colleagues will have read it. I think what I would say is that the National Audit Office report, which David referred to earlier in his his report. It was very helpful having the authors of that report in the room to give us the colour, if you like, around it, because I think people can read the words and put different inflections on those words. What we took away from that, and I think all of the colleagues at the meeting take away from it, is that this was actually a positive report. It was saying that we are making progress. We're not there yet on the aspect we're tackling. We do have a plan in place, an action plan in place, which we are working on, and we, as an audit committee, will be monitoring progress against that action plan as we go forward. And on the same sort of vein, the management assurance and the internal audit aspects that we looked at during the meeting, I think also say that we are we are getting better at doing both management assurance and doing internal audit, and that the results of what's coming out of those are being used to improve our processes and our controls going forward, but they are not there yet. That's clear that this is a trajectory that we're on. We're climbing up that path, but there's still more work to be done. On strategic risk and one specific area, with the health and safety, one of the things that we did say as a committee is that both the strategic risk is deemed, I think, really to include the high-level operational risks in there. Those should come through to the board at the appropriate time as well, so that the board has an opportunity to see them, but also to comment on them and to discuss them. I think that would be good governance around that. And then I suppose one of the things I would just mention is that this meeting had a Health Watch England part to it, which we do twice a year. And there are some concerns in Health Watch England around the Chief Executive and the Chief Operating Officer both going at the same, more or less the same time in the next few months. And I know that that's something which the Chairman will have, the Chairman of Health Watch England will have high on her agenda. And we also spent some time just looking at information security within Health Watch England, where there was a report which was not a very good report from internal audit. A lot of action has been taken by Health Watch England around that, and one of the things we made clear was that we wanted to see a very close coordination between the information security officers here in CQC and HWE to make sure that we're making best use of our expertise in that area. So,
thank you very much, Paul. I think I attended or do attend the Audit and Corporate Governance meeting, and I think the board needs to thank Paul for effectively, chairing a committee whose meetings are as long as this one, and with very complicated agendas, and with a lot of often difficult decisions and difficult decisions to take and discussions to hold. So thank you very much, Paul. Well, that brings the meeting to an end, unless colleagues have any other business they'd like to raise. So if there are any questions from the floor, we'd be very happy to take them. Thank you. Yes, that's a good idea. If the colleagues who would like to answer questions, they can all go and sit in next to Mr. Hogarth, and then we can.
Thank you. I'm David Hogarth. I'm coordinator of a small charity doing befriending in northwest London. I'd like to begin by giving you a very short sequel to what I was talking about last time. I went to a safeguarding meeting after the safeguarding meeting that I told you about, I put a sound record, an audio device back in my friend's room in this care home because I wanted to be sure that the promises that had been given by the home were actually being kept. This time the management found it, removed it, called me in to get it, and also said that if I and the next of kin and family didn't show any more trust in the future, that they would consider removing my friend from the home. I'm very glad to say that I came to the CQC about that. The CQC made it very clear to the management that they couldn't do that. And I'd like to thank the CQC for doing that. I had an email this morning from a daughter whose father is in a home in the Midlands who had similar sorts of problems to what I have. And she also had very nice things to say about the CQC. In her case, she'd found the manager extremely obstructive and defensive, telling her not that he couldn't be present when her father was receiving care and that sort of thing. But she called in the CQC, and the CQC told the manager that she's got to be more welcoming. But this lady also said that she really felt that her father would have suffered very much less if there had been surveillance at an early stage. And this sort of chimed with an idea which I'd had recently, that I think one of the, you see, in the, you remember when we were doing the guidance on use of covert cameras, there was a lot, and there still is a certain amount about saying, instead of using a covert camera, go and see the management. But apart from the fear of being obstructed and defensiveness, one of the things is that you feel that by going to the management, they will not have any more evidence than you have, because they're not there any more than you are at the time when these worrying things are happening. Would it be possible, you see, to go to the management? I think more people would go to managers if you could say to the manager, let's put in a surveillance device together and see what happens. But I think in the present situation, the answer would almost always be no. On the other hand, the CQC has clout, and if the CQC was to back this by making it a sort of almost a routine thing where there was a lack of evidence that would happen, then it would be very much easier for people to go to the management, and you would have a great deal more intelligence as well prior to your inspections. So I don't really want a particular an off-the-cuff answer about this, but just as something which the board and the executive team might like to think about. I did certainly find in my own case, going back to this question of I found in my case that CQC had quite a lot of clout, because I went to the CQC in this case that I was telling you about before I'd gone to the management. And when I went to the manager, I said I'd been seen the CQC. I'm sure he treated me a great deal better. And I think this is... I know surveillance is very expensive. If we go for these sort of things that Care Protect is now offering, like in Bramley House, where there's a whole system right across the board, that is going to cost a lot of money. But just putting in a single camera where there was where there was a worry is very much less expensive. So I just leave the thought with you.
Thank you. I think we'll take that on board and perhaps discuss it at our next board meeting.
Thank you, Chairman. Robin Pike, Hertfordshire Health Watch. I would like to take this opportunity to thank the board for taking questions from members of the public, because it is appreciated. Two questions that relate to items on the agenda this morning. One relates to hospitals, where a trust is composed of a number of different sites, hospitals on different sites, where the buildings on one site are modern, and the buildings on other sites are less modern. Such is the case at UCLH, which was inspected early in the new process. The Ear, Nose and Throat, Royal Ear, Nose and Throat Hospital, I think has been there in the Gray's Inn Road for 130 years, and the Neurological Hospital in Queen Square for possibly 150 years. How does the inspection system ensure that the older premises are inspected as well as the more modern?
Mike.
Should I take that one? You're absolutely right that premises can be very different, and you've given a very good example. In fact, of course, when we were talking about Bootham Park earlier, that was another example. At the moment, because of our resources, we are only attempting to inspect parts of hospitals, what we have defined as the core services. There are large parts of some hospitals that we don't inspect in this round. Now, obviously, we are thinking about what the next phase should look like, but the Royal National ENT will be an example, as was Queen Square, where we did not, even in our first wave, inspect those sites. And this is something we're giving considerable thought to what we should do in the next phase, recognising that there is an awful lot we can do, and so how do we prioritise? So I haven't got an answer for you at the moment, except to say it's very much on our agenda.
Yes, and I don't want to commit the CQC to anything, but I've been a patient at Queen Square, and despite its age, I had excellent care. Do we have one more question?
Can I just add the second question, Chairman, with your agreement? Would the board consider making more provision for public awareness of the work of the Commission? Because it's my feeling that currently members of the general public are not at all aware of the Care Quality Commission. And would the board consider initiatives such as a television documentary on the work of the Commission, or road shows, and possibly even facilitating attendance at the public board meetings of members of the public?
David.
Interestingly, Director of Comms, Chris Day, has had some preliminary conversations with a production company about a day in the life of, and I don't know whether we'll do it. It's a big deal, is that? It strikes me. But I think to your point, Robin, we have had some thoughts in relation to this. We also track recognition, and our recognition is going up in the Sentinel tracking, and so I think we need to continue to actually, do some of the things that we've been doing. Ultimately, I referred earlier when Lewis raised that important question about mental health services in York, about overview and scrutiny committees. My view ultimately is each council area, each CCG will have a link inspector or inspection manager who will be responsible for managing that relationship. And so I do think we need to do it through those routes as well. So I think it is something we're alert to. Capital development that's working its way through about improving our website. We've had previous discussions here about how accessible all of that is, whether it's interactive enough, and those kind of things. I think we need to use much more video messages in our website. You go on the BBC News website, you can listen to it, read it, watch it, and I think we just need to begin to think about some of those things. So we are doing that. Trying to get round this team, trying to get round hundreds of other people's board meetings is not something I think we can do. I don't know. We had a conversation earlier about managing people's expectations. I just don't think we can do that. And I do think, though, your question's an important one, and I think we need to think about using technology as well as actually developing those local relationships to do it. And let's say about the documentary kind of stuff. I thought last week, to the point that was discussed earlier, I think the state of care and the thematic reports are really, really important platforms for us to get over. And I only caught the 10 o'clock news on BBC on the state of care. And to your point, Lewis, I thought they got it absolutely perfectly. So by the 10 o'clock news, they'd got that report perfect. So we probably need to do more in preparing before our reports go out as well to make sure that happens. But important point. And people like you coming and telling your mates that you've been here and what we do is also important. I don't make that point frivolously, but actually people largely get to know because of word of mouth, because of what people say, not because we can push lots of stuff out and people won't read it. They come to it when they need it rather than when we push it out. So an interactive website is critical, I think.
An excellent question. I get, as colleagues many colleagues around the table do, the press cuttings service. And it is actually remarkable how much coverage there is of the Care Quality Commission in local media. Of course, it's something that unless one happens to be in the local area, you wouldn't know. But by looking at the cutting service, you can just see almost every time we publish a report on a care home, for example, in a particular locality, it is covered in the local media. So there is a lot more coverage, I think, than we would actually know unless you look at what's happening in individual locations. I think we have time for one more question.
Okay, very quickly, Brad McInerney, attending as a member of the public, really. Just on David's point there, really, I also think it's important about who communicates that message and where the trust lies with who communicates that message as well, really. I think there are multiple ways, really, but at a community level, that's what I find anyway, really. On one of your presenters, they talked about learning from other organisations. What I don't hear too much around the board really is where organisations come to CQC and learn from CQC. I think that's a real opportunity as well. 2 points I think probably for Eileen really on the staff survey and the response to concerns. And I think it might have been something that David mentioned at a board meeting some time ago about actually teams, inspection teams, having time to meet, whatever really, bearing in mind with the demands on them, etc., which they were coping. I'm just wondering whether or not there's been any changes or that's coming into the staff survey. And the other thing really is on the staff survey is if we just take communications, for instance, there's multiple ways of communicating, and I'm just wondering if we're diving deep enough to find out which aspects of communications probably work better in which teams and whatever really, rather than, we have that communication overarching approach. I just think we need to go deeper into that to find out what wouldn't work well within those teams and whatever, and also how we then would share that if possible. The bit about the response to concerns, really, and I just want to give an example, really, of someone who's very knowledgeable, who's very confident, and I've sent something through to Andrew on this and whatever, but still didn't feel they could share a letter that was sent to their families in respect to the CQC inspection. And I know we've heard it around the board, really, but it's hugely... brave isn't the word for it and whatever really, but for that person to even consider that. And the reason went back to the fact that their family was still in that home, and it was the power dynamics again really that they felt. So I don't think we should ever overlook that really. And you mentioned about listening to live calls as well in terms of the paper and developing it. I just want to step back a little bit from that really and just say, actually, with some of the people who've experienced this in their families, how they've been involved in shaping this, not to get it to, we listen to live calls, but I'm on about what I often call the pre bit, the early stages to it.
Thank you. Well, there's a lot in that.
Do you want me to respond to?
Well, I was going to say that when we respond on one particular issue, which is relating to the staff survey, because we do have an intranet for colleagues at the CQC, and I wonder, Eileen, in direct response to the question about whether we part of understanding what lies behind the staff survey, we look at how the intranet is being used, how often it's used, who looks at it, and so on.
I think Paul can add some colour, but certainly it is being looked at as one of a number of things we're doing, and just by way of giving a little further dimension to the various channels by which people communicate. It's instructive. We have a tool called Yammer, which is an internal tool, not unlike Twitter, which many of our staff use, but really very, very interesting to see the way that new cohorts of staff who sit across various directorates, they will do induction together, and they're actually forming groups of people who are communicating with each other and building that bond that is formed on the first formal day at work, to share experiences, share thoughts, share ideas about how to do the work differently. So we are drawing on a number of different tools, but perhaps Paul could talk specifically about the intranet, which is of course a key tool.
Thanks, Ellen. So we were talking about this earlier in the week in our executive meeting, Brennan. We were, Quinton, who presented earlier, was looking at all the different ways that we can improve communication so that it doesn't just feel like broadcast, and particularly email-based broadcast. Eileen's mentioned Yammer as a social media tool that allows people to join groups and talk amongst themselves, not unlike Facebook in some respects, but within the workplace. With the intranet, a bit like the internet, the website conversation earlier, pleased to say we now have some approvals from the Department of Health that we've been waiting for a little while, which means that we can make some proper strides in getting a website for the outside world and a website for our staff that's really fit for purpose. And partly that's about being able to give people the messages when they want them in a way that they want them, but it's also about making it much more two-way. So there's more opportunities for dialogue. So Quinton is a relatively new member of staff, and in the last 6 months is really revitalising the way in which we might communicate both ways with staff.
Well, thanks very much to the members of the public. It's always very good to see you here and to have your questions. So thank you very much. Well, that brings an end to the public board meeting. Just for colleagues, I think if we now have are we still going to have the board pad presentation? Okay, let's have just a quick coffee break, and then we'll reassemble for a demonstration of board pad.